Okay, we're going to officially get started. Hello, everyone. My name is Rose Gerber. I'm the Director of Patient Advocacy and Education for the Community Oncology Alliance. Thank you for being with us today. Some of you may know, or some of you may not know, which is why this is an educational series, that one of COA's initiatives is focused on health equity. In 2022, the COA Board of Directors made the determination that this was such an important topic that a standing health equity committee was formed. That committee is still in place and it has a new name now. And the name of the committee is the Patient-Centered Innovation Committee. And the reason for the formation of this committee was the knowledge and awareness that we are very, very aware, our physicians, our nurses, and of course our patients are aware that unfortunately disparities continue to exist. So this is why we have this important committee. My special guest today is my colleague, Shiela Plasencia, who is the Director of Practice Support. But in addition to that role, she also is a key lead on the newly formed Patient-Centered Innovation Committee. And today we're going to learn from Shiela about what our community oncology practices are doing to minimize or combat this very serious issue. So we're going to talk about the link between food insecurity and health equity, the role of our community practices and some of the support systems in the local communities, what solutions look like, and what each of us can do today. So Shiela, we're very happy to have you with us today, and thank you. And we can go ahead and take it from here. You can take it from here.
Perfect. Thanks, Rose. Hi, everyone. As Rose mentioned, I'm Shiela Plasencia, Director of Practice Support with Community Oncology Alliance. And in that role, I have the opportunity to work directly with our Health Equity Committee. So today, I'm just going to spend a little bit of time talking to you about how we address food insecurity at the community level. So next slide. So as we all know, hunger exists in our communities. We see it present in a variety of different ways. But food insecurity shows up locally in our neighborhoods, our practices, and our families, but its impact is national. So each community has its own patients who are struggling, but when we add those stories together, we see a nationwide issue affecting millions. Local experiences build into a national crisis that demands both community action and federal policy solutions. Next slide. So we just acknowledged that food insecurity exists in our communities. So as we think about this, we think about how it shows up locally. This does not mean having access. Food insecurity means not having access to consistent, enough, healthy, nutritious food. It's not just about being hungry. It's about whether families can afford fresh produce, whether a grocery store is within reach, or whether someone has transportation to get there. These challenges connect directly to the broader social determinants of health, like income, education, housing, and neighborhood environment. So when patients don't have access to these basic supports, their health outcomes suffer no matter how good their medical care is. Next slide. So when we talk about food insecurity, it's more than just a lack of food. It's about equity. The idea that everyone deserves a fair and just chance to achieve good health. Food insecurity isn't just about whether someone eats today, it's about whether people have a fair chance to live a healthy life. So when patients in low income, rural, or minority communities are more likely to go without nutritious food, that's not simply a personal challenge. It's a systemic injustice. Health equity is about fairness and justice, and food is at the very foundation of that. So no one should face worse cancer outcomes just because of their zip code or their income. Next slide.
Shiela, that part you just mentioned is very scary to know that a cancer patient who's already struggling with so much has to worry about, being properly nourished. Because so many patients will lose a lot of weight during treatment, some might gain a lot of weight. And we know that the oncologist and the nurses, the nutritionists on site are also trying to help them. So it's just very scary to know that this is an additional burden that we don't want put on patients.
Right. And just to make sure that we're doing all we can to assure that those patients have the best care, and that means all parts of their care. Yeah, so where community oncology fits in, I think we play a really strong role in where we fit in, and this is the part that makes my heart happy when we're talking about this issue. So community oncology practices are on the front lines. We see the patients more often and more consistently than almost any other provider. That puts us in a very unique position to notice when someone is struggling with food insecurity. So we know if a patient has lost weight, missed appointments, or mentions financial stress. Unlike distant health systems, we're embedded in the community. We're trusted by our patients and connected to local resources. So the trust that trust means that we have the ability to intervene early. So screening for food needs, referring to community partners, and sometimes even offering on-site support, which we'll talk about in a little bit. So this is where community oncology can make a real difference beyond the infusion chair.
Sheila,
So
can you
yeah.
educate our audience too about the screening for food needs? Because that's a question that I've got a lot over the years, because I know that a lot of times patients, when they go into a practice, they're already being asked a lot of questions. And sometimes admitting to struggling with food is something that someone doesn't want to admit. So if you can explain how the practices are screening for that.
Sure. Yeah. So there's a variety of different ways that this can happen, but I think the key way that we are able to intervene here is because we are building those relationships with the patient from the second they step into our doors. And so if teams have a social worker, perhaps the patient is meeting with the social worker. If a patient is willing to admit that perhaps they're not food secure, then they can make that referral to the social worker. Sometimes if the patient isn't comfortable telling the first staff team members that they meet with about their, the difficulties they're having around food security, they may be willing to discuss that with a social worker. And the social workers are uniquely trained to be able to have those types of conversations with the patients. So it just kind of depends on what model the practice has. But then oftentimes also practices are doing some social determinants of health questionnaires when they first take the patient into their centers. And sometimes on those questionnaires, the patients can just check a box whether they have, regular access to food. So it's a variety of different ways. But again, I think the unique ability we have to meet with our patients where they are and establish those excellent relationships lends us to be those kinds of partners for the patients.
Thank you, Sheila.
Sure. So can you go to the next slide? Sorry. So basically, I want to talk real quick about what's working in our communities. So this is the part that's really exciting to me, because I think the practices are also very different, and what works in one community may not work in the next community. So these are just some examples that I'm aware of that I wanted to make sure that I shared with everyone. So on-site food pantries is one of the things that I've seen practices doing. And basically the model typically looks something like they provide 2 weeks worth of food every 2 weeks to a patient. And they kind of coordinate this with their social worker and the nutritional staff to make sure that the foods meet the patient needs. So why this works is it's immediate. So it immediately gets them access to food. It's consistent and sustainable. And then it's super easy for the clinicians to refer to because it's right there in their own clinic. So this is one model that I think is a great thing for a practice to set up if they're able to do so. Then a couple of the other things that I've heard about are food prescription programs. And so basically the food prescription programs are providing what you would say like a produce prescription to the patient with an education model. So basically giving them the food or access to the food, but then also educating them on why this is important that they eat these specific foods, etc. And this type of program is usually combined with, the social worker, a dietitian that might be on site or off-site support. And some of these programs can even be funded through like different grants or local foundations in the community, etc. And then, why this works, it's because the clinician is who's prescribing this healthy
Mhm.
food. And
Yeah.
so that really makes a difference when you're trying to get patient buy-in to some of these programs. If they feel like their physician is saying, this is what's going to be best for you right now, and this is how we can help you be successful, the patients really take that to heart. They really listen to what their physicians have to say. And then,
Go
oh, did
ahead.
you have a question, Rose?
No, I just think I can speak for a lot of patients where when the physician is prescribing it, because I know that even to this day as a long-term survivor, I never want to let my oncologist down. So if whatever she tells me to do, I want to do. And I know that so many patients feel exactly the same way. You just want to make your oncologist know that you're doing everything possible. So I really love that.
Yeah, and it's um, oncology care is such a team effort.
Mhm.
And I think that's one of the things that the community oncology practices are so well situated to show the patients that this is a whole team of people taking care of you here.
Yeah.
So the physician's leading the charge, of course, but there's a whole host of other team members that are wanting to take care of the patients. So then a couple other things that I just like to mention real quickly is transportation support. So we all know that if the patients can't get to their appointments or they can't get to the grocery store to get the groceries and the food, that's definitely a barrier to care. So like American Cancer Society has their Road to Recovery program, and a lot of their practices that we are aware of have ACS providers, volunteers within
Mhm.
their practices that help get their patients to appointments, et cetera. But then they also often help get patients to grocery stores or help to get food delivered to their homes. So, transportation support is a key component of making sure our patients have access to food. And then I was just at a restaurant over the weekend in Virginia, and I saw this really cool thing on their menu. So thinking through like local nonprofit collaborations, this local restaurant has a specific bread basket on their menu. And every time anybody orders that bread basket, a percentage of the sales of the bread basket go to their local cancer center's food bank.
Wow.
So I thought that was such a cool
That
idea,
is
because when
amazing.
we
Yeah.
think about local nonprofit collaborations, you always think of the nonprofits that you're instantly familiar with, but I
Right.
think there's also an opportunity to think through like a whole host of ways that you can actually get your community involved in helping to support your cancer patients and get them access to the food that they need.
That's
Next
wonderful.
slide. Do you have something else, Rose?
No, I think that's wonderful. You know, those 4 points are so interesting. I personally think the in-house food pantries is absolutely remarkable. That's just such an incredible asset for patients to have right there. It's kind of like an in-house pharmacy in a sense. You're going to do it. That makes it that much easier for the patient. It takes another burden off having to go somewhere. So I think those are all wonderful, wonderful resources.
Yeah, it really is. I mean, when we think about our community practices, so many of them are very, very rural. And
Mhm.
so to be able to set the patient up with access to the food resources that they need right there when they're in our center
Right.
is just phenomenal. And I think, like when practices can pull something like that together, it's just an amazing opportunity to be able to serve our patients.
And they can retain their dignity as well, because when cancer patients are in that state, they don't feel like themselves as it is. So to have to go and do all these other extra things, knowing, like you said, it's a whole team of people taking care of the patient down to the most core need, which is food, it is so valuable. It's so great to know that all our centers that our community cancer centers are doing this.
Agree. And I think it really just kind of helps remove that stigma, Rose,
Yes,
because, having it right there in the center, they see that they're not the only ones that have
yes,
those types of needs. And so I think that just also helps break down barriers. It's not one more place that they have to go. They don't have to fill out a form or stand in a line where everybody's, seeing them there. So
right.
I think that's like I said, I think we're so well suited to be able to
Mhm.
provide these services to our patients.
Yes.
So equity first means upstream action. And I really want us to spend some time focusing on like, what does it mean when we talk about going upstream? What it means is that we're addressing the root causes of food insecurity before they lead to poor health. So think of a patient who misses meals because their social security check doesn't stretch far enough. Or like we we're just talking about, a rural family who has no grocery store within 30 miles. These are real situations that our patients face every day. Those are upstream problems. So poverty, transportation, housing. If we only focus downstream, we're going to be handing out emergency food bags forever. And, I know we talked about doing that, and it's great that we can do that. But if we go upstream, we advocate for living wages, invest in better transit, and support grocery stores and food deserts. So this is just how we think about creating lasting solutions. Next slide. So what can advocacy do? Because we are an advocacy organization. So we want to make sure we spend some time talking about, how we can all be a part of that advocacy team. So policy change only happens when people speak up. And Rose knows this better than anyone. And that includes all of us, not just a few of us, not just those that we think are really good at doing that, but everybody has a story to tell. So you don't need to be a lobbyist or an expert to make an impact. Call or email your representatives and tell them why programs like SNAP or Medicaid nutrition benefits matter to your patients. Share stories from your community. I know Rose is always asking, for you guys to share stories with us. The stories are so, so important to COA and the work that we do. Our lawmakers remember the stories more than they remember the numbers. And don't underestimate your influence as a healthcare professional, or a caregiver or an advocate. Your voices carry the real weight. So using our voices collectively is how we make sure food access is treated as the health issue that it truly is.
This is all, Sheila, when I look at the slide that you just had, I really, again, can you go back one? Because I think it was an important slide. Well, they've all been important, but the normalization of discussing food needs, because again, for a lot of people, that would be very difficult to say, our refrigerator's empty, right? Or
Right.
the paycheck isn't stretching. So if this is normalized, then people are going to be more at ease. So I think just bringing this to everyone's attention is so valuable. What does like funding this, the routine food screening look like? Is that something like by grants, or what are we kind of suggesting here? Is this more like the systems or individuals?
So my thoughts on this personally are that if you're meeting with your patients when they first show up to your facility and they're going to get started on their cancer treatment, is have this part of your routine conversation that you're having with your patients. So I think one of the easiest ways to do this is to have this part of your SDOH assessment that you do. And most practices nowadays are doing some sort of SDOH assessment with the patient upon their first or second appointment, so that you can have an understanding of whether they already have some barriers that might present issues with them staying on consistent therapy. So if you're openly talking about that with your patients at their very first or second appointments, it's going to make them more at ease about continuing to have that conversation with you. And I think it's a really easy way to learn where the patient is in response to the food that they have access to. And then if you do have that social worker or that dietitian on your staff, you can make that referral to that person and get them involved in whatever their needs are right away and get those addressed.
Thank you, Sheila. And also to anyone who's listening, if you have any ideas or if you want to share anything that you're doing, you can definitely put that in the chat. We'd love to hear from you as well.
Absolutely. Yeah. So next slide. So how can you help today? So this is one of my favorite slides because I think sometimes it's hard for people to start. They know they want to help or they want to take part and do something, but they're not sure how. So I'm just going to talk about like some simple, practical first steps that we can all take. So the first one is what Rose and I were just talking about. Start by having that open conversation with patients, your colleagues, and your neighbors. Asking about food needs helps break that stigma. So the more comfortable we all become with having those types of conversations, the better we're going to be able to serve our patients. So support local food banks or community gardens, even if it's just volunteering for a few hours or making a small donation. And then advocate your practice by encouraging routine food insecurity screening. So what Rose was asking me about. And then finally, sharing those patient stories. When people hear like the real human impact, that's what really drives change faster than the statistics alone. So I think if I think through all of these small actions, they end up making a big difference. One of the things that I think about that we did with our own family was we volunteered once a month at the local food bank. And it was a simple task of, they had cans on a conveyor belt and we just wrapped labels around those cans of food that were going to be distributed. So there's a way that you can help if you want to help. And it may be you have a lot of time to give or you have a little time to give. Somebody can figure out some way to put you to use and get you helping with this problem.
Shiela, when you talk about the stories, I'm reminded, I won't name the cancer center, but at a cancer center that I went to, one of our community practices, they learned, this was many, many years ago, where they learned that a lot of their patients were struggling with food insecurity. And the way it came to their knowledge is they would have snacks, in the area where the patients were. And just within minutes, like this, the snacks would be gone. And even when the more that they left out snacks, and what was happening is some of the patients were, just sneaking some extra food, extra snacks to take home. But this was nothing that anyone should have been embarrassed about. It was an educational moment for the practice as well to say, wow, this is really happening. So they actually started doing more like providing a little refrigerator that had yogurt, string cheese. And that was kind of the beginnings of them, recognizing that they needed to focus more on food insecurity. And it was just really remarkable to me. Like you said, I don't remember every single detail, but I remember that part of the story. And it was really moving, right? To recognize like, oh my gosh, cancer's so overwhelming as it is, but now to not have the food, you already feel sick from cancer, then you're going to be sick because you're hungry. And everybody knows when you're hungry, you're not nice. You get mad. So the food's going to make people happy.
Yeah, well, and if you're hungry, it's hard to focus on anything else,
Yeah.
right?
Right. You can't take care of yourself, right?
Yeah, exactly. And again, Rose, I think all of the things that you just said are some of the key components to why community oncology is so well centered to take care of and address this issue of, patients that are in need of food. So next slide. So this is my last slide, but one of my favorites because I love the idea that food is medicine, and I really believe in this. So we've all seen those T-shirts that say "hangry." When you're
Right.
hungry and you get angry, like what Rose was just saying.
Yeah.
You can't fight cancer on an empty stomach.
Mhm.
So I want to thank everybody for their time and attention today, and for the work that you're doing in advancing equity in your own communities. I think food insecurity is urgent. Our patients can't wait because cancer treatment doesn't pause when there's no food on their tables. So by working together, we can turn awareness into action and make sure no one has to fight cancer on an empty stomach. Health equity truly begins with food, and we have the power to make a difference right now. So again, thank you, Rose, for inviting me to speak today. This is a topic that's super important to me, and I appreciate the opportunity to discuss this with everyone.
Thank you, Shiela. This is really good information. And Shiela, do you want to spend a few minutes, if you'd like, to talk a little bit about the committee that you had, what is currently renamed Health Equity Committee, to our Patient-Centered Innovation Committee? I know that for anyone interested, we do have the members listed on our website, so you're free to check that out. But did you want to talk anything about the committee, Shiela, some of your ongoing work, or how often you meet, anything like that?
Yeah, so I can real quick. So as Rose mentioned, it initially started as our Health Equity Committee that was driven by our board of directors. because there were so many of us just feeling like there were a lot of areas that needed to be addressed within the umbrella of health equity. So the committee was established. And then we've done a couple projects around like patient navigation and seeing a good success there. And we've had the opportunity to do workshops for a variety of our community practices that are involved with COA. And through those workshops, we've really been able to educate practices so that they can go back to their practice and implement something. This specific topic that we've worked on lately has been patient navigation. So they've shared best practices with each other and learned from each other how they might establish a more robust patient navigation program. And so that's the work that we've been focused on lately. The reason that we modified our committee and changed it from Health Equity Committee to the Patient-Centered Innovation Committee was because as we were working with the practices, we realized that there was such a broad range of areas that we could work with them on to better serve their patients, that we felt like it needed to be expanded beyond just health equity, but then, some of the innovative concepts that practices are putting into place to help take care of their patients. So like Rose said, the information for the committee is on our COA website. I'm the COA liaison for that committee. So you can always reach out to me or reach out to Rose to connect with me if you have any questions or would want to get further involved with that committee. I'd be happy to help you do that.
Thank you, Sheila. This is really wonderful, helpful information. Next slide, please. I just have a few little announcements before we say goodbye to each other for the day. And that is just a reminder that Sheila's slides, just like all of our advocacy chat guests, will be available on our YouTube page. So please go to check them out. And this topic, to demonstrate that we are very dedicated to this issue, we have had previous speakers along with my colleague Sheila, who just gave a wonderful presentation. So if you go, you'll see 3 different presentations on health equity, one from Dr. Richard Martin from Tennessee Oncology. You'll also see a presentation, advocacy chat from one of the national advocacy organizations that is the Cancer Support Community, which is very well known to cancer patients. And our guest there was one of the executives from Cancer Support Community, Audrey Davis, who's really well known in the health equity space. And many of you also know Alan Bach, from the CEO from National Patient Advocate Foundation. So now you have 4 different advocacy chats where you can go and learn from a few years ago to the very timely one today. And again, it is National Hunger Action Month. So hopefully we can all do something that Sheila had suggested on one of her slides. Just a reminder of the different ways that you can stay engaged with CPAN, participate in these chats. Thank you so much. This year we've had over close to 1,000 participants, so this has been really great, who are either live or watching us on YouTube, Facebook. It's so great to know that you're very interested in these advocacy chats. We appreciate it. Visit our website to learn more, and then we have one last slide, so I can tell you about next month's guest. Okay, so many of you may know Christine Pfaff. She's our newest COA employee. She is a director of clinical initiatives, and she is a licensed pharmacist. We're going to be talking about one of COA's favorite subjects, which is PBMs, and the title for next month is Cancer Care Hijacked: How PBMs Are Blocking Patient Access to Medication. So not only will you hear the patient perspective, but you'll hear from a very knowledgeable pharmacist. So thank you so much. Enjoy the last few weeks of summer, and summer ends on August 22nd. So try to pack in as much relaxation time as you can around the day job, of course. Thank you again, Sheila, and thank you to everyone who participated
Thanks
today.
a lot, Rose. Thanks, everyone.
Bye-bye. Thank you.
Bye.